Thank you so much for your introduction. And I'm very happy that you gave me the opportunity to share some information about ultrasound. And this is my disclosure. We use ultrasound now for more than 10 years, and I start using it to treat complications. And then since 7-8 years, we thought if we treat complications, why not rather prevent them? So I start using it in my daily practice. And along the way, I found out that it was also very useful to improve my treatment outcomes. But let me go one step back for you because not everybody works with ultrasound. How does ultrasound works? What happens is that ultrasound waves travel through skin and they hit certain structures. And if the waves hit something hard, all the waves will be reflected and you see a white image on your screen. So think about bone, teeth, their heart. The opposite is if all ultrasound waves travel through a structure. That's fluid. So think about cysts, vessels, the ultrasound waves pass through and you see a black image on your screen. And then of course, as in daily life, there's a lot of gray between white and black. So that's what you see with ultrasound, but every structure has its own echogenicity. And we are used to these nice and neat organized images in our anatomy book, or to these cadaver images. Ultrasound, if you look at this black and white grayish stuff, I can imagine that in the beginning it really looks messy to you, but if you develop your eye for it, you will see that these images are as organized as your anatomy book, but they're in black and white. And your most easy landmark is bone, because your ultrasound waves travel through skin, they hit your hard structure as bone is, it will be reflected and you see this white line underneath. And then of course on top we also have the dermis. Here you cannot see that bad, it's a black little line. We have the dermis and here you have your muscles. And muscles, the facial dynamic muscles, contain a lot of fluid. So they look dark gray, they're linear band-like structures, they go from bone to skin, and this is a facial muscle. The exception is the big masseterian muscle. So the masseter muscle, the temporal muscle, they do have the same background, but they are so big they have septae in them. And then of course it's just a matter of applying layers. So again, we start with the epidermis, this darker layer, the dermis. Subcutaneous tissue will always look a bit lobular, as the fatty lobules will look like this. Smas, masseter muscle, and here we have this cloudy homogeneous area as your parotid gland. So if we look at the bone, the layer underneath, there's sometimes a gap or sometimes it's a little eye. And these are your notches. And in this case, look where my probe is positioned. This is your infraorbital foramen. And if you put the color box on so you can see vessels, you will see here the infraorbital artery coming out of the notch. So what you should try to do is the anatomy that you already know, apply to the different layers of where the probe is positioned. So luckily we have this little head over here, and this is where the probe is marked. The marker of the probe is corresponding here at the cranial side of the left side, and this side of the probe is going to the zygomatic area here. And then just apply your anatomy. So we know we have a temporal bone. Bone is white, it's your last layer. On top of the bone, we have a big muscular temporal muscle. So it's black, but it has a lot of white septae. And then in the middle of the screen, this is how fatty tissue looks. It's always a bit lobular and it has this white little septae in it. And there's too much text, but if you look in this area, you will see that this resembles the subcutaneous tissue, resembles a bit this area. This is how fat will look to you, and this is the superficial temporal fat pad, nowadays called the intermediate temporal fat pad. And you know it is enveloped with fasciculates, and fasciculates are dense and they will look white on ultrasound. So you see here is one layer, there's the other layer of the deep temporal fascia. They're fusing here. And here we have the superficial temporal fascia. subcutaneous tissue, dermal, more white, and the epidermis. So again, just to help you to get a little bit through the anatomy, my probe is positioned here. And this is a little bit difficult because now you have to flip your head around. Because the probe is now cranial. So here we're going to the zygoma, and here we are where the masseter and your jawline would be. That's this area. And that what you see is this homogeneous cloudy structure. Glands will look like this. And this is your parotid gland, because you know from anatomy that your parotid gland is in this area. Subcutaneous tissue, skin, big masseter muscle, and the white line is your bone. So just apply your knowledge and you'll find your way through ultrasound. Look where my marker is. The marker is at the zygoma. So here's the zygoma, and here we are at the nostrils of your nose. So this is the midface. Here we have the midface. And what I like about ultrasound is that you can see that this big subcutaneous fat compartment takes in a lot of volume if you compare it here to the zygomatic area. And what you also see is it's not one layer, it is a layer, but it's an orange sliced form. So it differs in thickness, which is important for you to know if you start to inject. Here we have the deep fat pad, and again, the white layer is bone, the maxilla bone, but here we have the zygomatic bone. And of course, you can see vessels. So vessels are black because they contain fluid, but if you put the color box on, you will appreciate that they're blue or red. Not as in your color box, but it's more the movement of the transducer. So if we look in this image, you see that I'm compressing with my probe. And an artery is not easy to compress. A vein is easy to compress. So we're looking here, bone, masseter muscle, SMUS. We're looking at the facial vein and the facial artery. And you see by compression that I'm able to distinguish between the two of them. But also veins are more floating in their behavior and arteries are more pulsative. And as you know that, you can apply this to the safety of your filler treatments. So look where my probe is. This is the mark of your probe corresponding with the left side. And here the other side is at the modiolus. This is where all your muscles come together. We have white lines here, teeth, they're hard, they're reflective. We have a band-like structure being your orbicularis oris muscle and then the subcutaneous tissue. Now, if we put the color box on, you see that in this patient, the supralabial artery runs perfectly in the muscle. This will take a couple of seconds, and if you apply this before treatment, you know now that you can safely inject her in the superficial area. As you can see all your fillers, all your structures and your veins, you can also see all different types of fillers. And as we're talking here about stillage, about hyaluronic acid fillers, I will show you how they look on ultrasound. They are able to bind water, and you will see a black, overly shaped, well-defined deposit. So here between markers, this is how hyaluronic acid will look to you on ultrasound. And if you want to prevent complications, this is very important. Inject into the correct layer, but not only to prevent them, but also to get the maximum effect out of the filler that you're using. So one more time, here is epidermis. Oh, I'm sorry. Then we have the dermal layer, the gray underline, subcutaneous tissue, lobular with a little bit of septae in it, SMUS, masseter muscle, we're here. And we are going to inject today in this subcutaneous area. But if you measure it, the subcutaneous area here is 1 millimeter. That's not a lot of room to inject. And in the thickest area, it's 3 millimeter. Now, if you do that between your fingers, you can imagine that you have to get your cannula in, you have to get your filler amount in. It's not that much room that you have, and you want to be in the right layer. Sometimes you have more room. So if you look at the thickest medial fat compartment, in this person, it's 8 millimeter. In another person, it's 6 millimeters. So it depends per person. And this area above the parotid gland, we're here now, is often a very small layer. We're talking about 2 to 3 millimeters in general. And if you want to place your product where it should be, you want to be here. So this is my cannula. the subcutaneous layer, and you can see my cannula, here is HA, my cannula is injected in the right layer, leaving the HA, the black ovally shaped deposits here and here in the right plane. And if you look afterwards with ultrasound, this is the subcutaneous layer, the SMAS, and here are the hyaluronic acid deposits placed correctly under the dermis and the epidermal layer. But here my cannula glides without any problem. It goes into the fascia blades, and we do see this a lot at our polyclinic. People have late onset nodules, and they are caused by filler material, hyaluronic acid, after 3 years injected in the fascia. This is the subcutaneous layer, the dermis and the epidermis. Here is the fascia, and it's injected in the wrong layer. So we're again at the zygomatic bone. Here is the SMAS. There comes my needle. I'm going under the SMAS, injecting in the right plane, leaving my material under the SMAS, hyaluronic acid, in the right injection plane. But we often see that it's injected above the SMAS in the wrong injection plane, leaving your patient with complications or visible nodules. So here again, parotid gland, my cannula is exactly in the subcutaneous layer, leaving some HA. And this is parotid gland muscle, epidermis, dermal, and the filler is placed correctly. But here's the opposite. And we do see a lot of filler being injected in the parotid gland. So there comes my needle, and your patient will not say, ow. It's not, for me, even clear. The difference between subcutaneous tissue and parotid glands feels the same, actually. So here I'm gliding very easily into the parotid gland, and I can even lift it without any notice for everybody. And then your product is in the wrong layer, leaving through abscesses or through chronic inflammation responses. So you want to prevent complications, but it's also a matter of filler characteristics, why we have to inject in the right layer. So Silagia has a lot of different products, and that's not because they had so much time on their hand or they were just so happy making different products. The products are all different. And if you look at this 26 milligram per gram, it leaves you with a completely different characteristics compared to a 16. So you have to inject them in the layer if you want to get the most out of the product where they're supposed to be. So, or at the periost, or very superficial, or more in the deeper subcutaneous layer. And if we look at this image, this is the subcutaneous tissue, you can see that these filler deposits fits in the area. But if you look at this image, you can almost imagine looking at this, that these big volumizing deposits are way too big and way too heavy for this subcutaneous area. And if you look at mobility, so let me tell you where we are. This is, we're here at the orbital rim. So this is the orbital rim. This is your orbicularis oculi muscle, the SUF, deep fat pad, the pre-zygomatic space, and this is your superficial layer where you just saw the product injected. Now, the orbicularis oris muscle is the floor of the superficial fat pads. And look what's happening if you smile. Look at the subcutaneous layer. It's been pushed up. So the movement of your face, the dynamic muscles, are causing movement of the superficial plane. And if you do too much heavy product in this, you'll have a very unnatural appearance. So looking at Hydromax that's injected in the dermis, the Hydro and the Hydromax more a deep subdermal, but also superficial in the subcutaneous fat pad. We want to inject it here between this layer, between the epidermis and the dermis, or we want to inject it very superficially. We do not want to inject it here because then your tissue will not have any effect for your client. So somewhere you will see my cannula coming in. Here it comes from this area, from the left side. No, this is just me showing the subcutaneous fat pad. I'm always checking For vessels, are there any variations in my way before I inject? There you saw a small artery pounding, but not really that special. So here is my cannula, and it's a little bit too deep. So I retract it, and now I am very superficially. Can you see that? This is injected superficial to the almost to the dermis. And in comparison, I will inject here in a deeper layer a hyaluronic acid stillage product that is meant to be placed more deep. So here's the superficial one, and here is the deep injection. And then, of course, we have the very superficial coming in from the right side. You see, I'm almost attached. The product comes with very small 30 gauge needles, but this is a 30 gauge cannula. Otherwise, I wasn't able to visualize it on the ultrasound. But you see that I am so you see that here I'm attached to the dermis, leaving my product in the right layer because you don't want to have it too deep in this case. And then if we look at the product, here is it injected underneath the dermis. And here you see the, once again, this is the product I injected more into the deeper layer. And oh, I'm lacking time, but I think, oh, let me go back, because here you can see very superficial, but they're too small, injected the hydro. So the hydro max and product that should be more into the deep subcutaneous tissue. Thank you very much. I hope you have some questions for me, but I leave that to Dr. Ellie. Thank you.
All right. So I have a couple of questions for you, Dr. Schalke. And the first one is, you mentioned that ultrasound in your clinic and for your academic purposes and for your clinical purposes is more for complications. What would you say, how far off are we from using ultrasound at the side of the patient, so at the bedside, while we are performing injections like this? How far off are we?
It is my daily business. I use it every day. I don't use it that much for botulinum toxin, but I use it before, and I actually do a lot of deep filler fat injections, ultrasound guided, because it leaves me, I know where I am, and if you are in the right plane, you have much more benefit of your product. But that's me. We have a lot of physicians in the Netherlands doing that. If you look at medicine, we're a little bit behind. A lot of specialties already use duplex ultrasound. Cardiologists, orthopedic surgeons, anesthesia. So we're a little bit behind. I hope for the patient's sake that it won't be too long. And the good news for the physicians is it's really fun. You see what you're doing, you see your anatomy, and it brings, in the beginning, you have your learning curve. But after that, it's really fun to do it.
Okay. In terms of the technology, of course, you know, when you're at the bedside of the patient, you've got your syringes, you've got your needles, you've got your whole kit, you've got your sterile pack, you've got everything ready. I have seen sort of prototypes where the ultrasound probes are really kind of small and they handheld, almost like they can be kept in your kind of white coat pocket. Do you think that this is achievable, and do you think that this will be able to be made for the sort of mass market? Of course, you know, with subsequent and necessary training. Do you think that that is a reality that may happen shortly?
Yes, they're already being used a lot in America and also in the UK. I have a couple of them, and the images I just showed to you are with a very high-end ultrasound device. I use it for research. But I also use these portable ones. I use them to treat my vascular complications that we see. And it's like iPhone. So you will see that the quality of all these portable ones will increase very rapidly in the future. But even now, if you use them, I'm very happy with the quality.
Okay, good. And one last question, Dr. Schalke. You said in your presentation, you said that every filler is recognizable. Does this hold true? I know that you demonstrated with the 30 gauge, the placement into the very superficial dermis or the dermoepidermal junction of hydro. So does the same rule hold that hydro that is non-cross-linked is still recognizable on ultrasound after injection?
Yes, if you look closely and you develop your eye, I would be able to see it, but this is an 18 to 22 megahertz. You also have 70 megahertz, and then they're more than visible. So it's also dependable on what size you're using. But even with these, with a 12 megahertz probe, I'm not too sure. That would be probably more difficult to visualize.
Okay, cool. I also assume that clinically, as it's non-cross-linked, the product doesn't linger on in the skin for too long. So okay, all right, no worries. Thank you very much for your presentation and for answering the questions, Dr. Schalke.